Hello, everybody, and welcome to the webinar in relation to living with fibrosis, challenges, treatments and innovations. This event is part of the EFCA Talk series and is organised with the framework of the European project FIBROTARGET, which EFCA is proudly partnering with. FIBROTARGET project is led by Professor Vermeer from KU Leuven in Belgium, which focuses on validating novel immunotherapeutic targets for fibrosis in IBD. The project aims to gain patient and regulatory approval for non-invasive imaging tools that will improve diagnostic and prognostic capabilities for fibrotic IBD. Until now, therapies for IBD have only targeted inflammation. Even current treatments do not resolve the issue of how to predict who will develop fibrosis and strictures. So contributions made from this European project will be certain to leave a promising legacy in health systems and outcomes, especially for those living with IBD. So we have a very exciting hour ahead of us. We will be joined by Professor Vermeer from KU Leuven in Belgium, Professor Amusi from Humantis Research Hospital in Italy, and Professor Raja Atera from the University Hospital of Efteling in Germany. So welcome and thank you for joining us.
Thank you.
Just before I pass over the stage to you all, just for anybody watching, if you have any comments or questions, we'll pop them into the chat and that'd be great. We will also, after this presentation, we'll see if we have some questions, which we'll put to the panel. We will then speak to some patients who currently live with fibrosis, and then we will have a roundtable discussion. So anybody online, please pop in your comments or questions into chat and we'll hopefully get through them. So Professor Vermeer, I'll hand over to you.
Yes, and thank you very much. Thank you for having us all three here this evening. So in the next hour, we will be listening to your stories and we will be answering the questions you might have around fibrosis in inflammatory bowel disease. Can I perhaps have my slides? Okay, and you can give the next slide. Indeed, we are here with three physicians, two very good friends and colleagues. Within the European FIBROTARGET project, we collaborate with Professor Alessandro Armuzzi from the University of Milan in Italy, and also with Professor Raja Atrea from the University of Erlangen in Germany. And we also have the University of Barcelona on board. So you can have the next slide. And I would like to start by showing you the long list of new treatments that we currently have for treating patients with inflammatory bowel disease. You've seen that over the last 20 years, we have absolutely made progress. And now we are having various drugs, biological agents, but also pills, small molecules that belong to various classes of drugs, and that all work in patients suffering from Crohn's disease or ulcerative colitis. You can go to the next slide. And we see that thanks to these agents, thanks to these medicines, we see that many patients will improve. Many patients will also heal their bowel. And what we see at the inside when we perform colonoscopies or what the radiologists see when they do imaging is that there are different phases of healing. On the left top, some patients heal without any scarring whatsoever. In the middle top, you see that patients may heal with some kind of superficial scars, these whitish stripes. To the far right, you see that some patients heal with quite a lot of scarring on the inside. And then we move to the bottom. Some patients will heal with making these pseudopolyps as scarring tissue. In the middle, you see patients that scar and that heal, and they lose a bit the motility of the bowel. And to the far right, you see that, and this is the problem we will be discussing, that in the process of healing, the bowel may also become more and more narrow, as you see with the two red arrows. Next slide. So, and we are having the medication that heals the bowel, but we cannot really tackle until today this scarring and this fibrosis or narrowing. So a stenosis or a stricture is the same word, is nothing more than a narrowing of the bowel. Because of this, what you can see is that just above that stricture or stenosis, the bowel may become dilated, expands under the pressure because the contents of the bowel cannot pass through the stenosis. So when we see this pre-stenotic dilatation, for us as doctors, it is an alarm symptom. It shows that the stricture or the stenosis is very already advanced. What you can also form or make is in the area of the stenosis, because of the pressure that often there is a perforation, and you can make a fistula. You can make a hole in the bowel, and the stools and the content of the bowel will come out and they will find their way out. If they find their way to another organ or another piece of the bowel, you will form a fistula, a tract. It can also be that all the stools is accumulating in the abdomen, and then you form an abscess. So often stenosis and fistula in the bowel go hand in hand and are occurring together. Next slide. And I show you an example of one patient that to the left had already a surgery in 2015. And after the surgery, the disease, the Crohn's disease, came back in the segment that was previously healthy, the small bowel. And so the stenosis was resected, the small bowel and the large bowel were connected again, but in the new last part of the small bowel, there were again ulcers. I cannot go into details, but this patient at that moment decided not to go for any treatment, but wanted to be followed up and see what happened over time. In 2016, you see that the lumen of the bowel became already more narrow. No treatment was started. In 2018, you see that it becomes even more narrowed and the ulcers that you start to see are larger, up until 2019, when the bowel was completely obstructed again. So this is one example of what happens if you do not treat the inflammation that is there, that if you leave untreated, the bowel will gradually start to become more and more narrow, form fibrosis with inflammation. And the two are also influencing each other in a negative way. The more inflammation, the more fibrosis you can make. And also when there is fibrosis, it's very difficult to treat the inflammation, which is also present at that particular segment. Next slide. And this is another example. You see here a narrow segment with a wide ulcer, and this is just a close-up. So we can no longer pass with the colonoscope. You see that there is inflammation. And so inflammation, fibrosis often go hand in hand. Next slide. And this is the big problem. If the surgeons often need to then operate because all the good medications that we are having are treating inflammation. We do not have a treatment to treat fibrosis or stenosis and to treat really the thick bowel wall that you see here when a surgeon operates on the small bowel. Next slide. And so to finish some figures, we know that 20% of patients with Crohn's disease already have strictures at the time of diagnosis. We also know of the patients who do not have strictures yet, that 1 out of 5 will progress towards making strictures after 5 years. And we also know that already 1/4 of the patients will need surgery within the first 5 years. And you all know that this is not the end of the story in Crohn's disease, because you can resect the part of the bowel which is the most sick, but the disease may always come back on other healthy parts. And in fact, we know that in more than 3/4 of the patients, the disease will come back in other segments of. Next slide. So this is what we are trying to tackle within the European FIBROTARGET project. We are trying to find what are the drivers of fibrosis and stenosis. Can we identify these drivers, and can we perhaps develop drugs, medicines to treat really the fibrosis? We also are studying if there are better ways of diagnosing strictures early on and not having to wait until they are fully formed. And finally, in the last phase of this project, we hope to start a pilot study with a new drug to treat fibrosis in patients with Crohn's disease of the small bowel. With this, I would like to thank you, and I'm happy to give back the floor.
I would just like to say that if anybody has any questions or comments, please pop them into chat. I think what we will do now is hear from some patients on how the living with fibrosis is, and we're joined on stage, and then we will come back for a round table, which is always interesting from a physician's and a patient's perspective, but a very important topic. So, it's not exactly a question. I just have a comment about an IBD dietitian, and fibrosis is a big challenge. And I think that is something that we will discuss probably at the round table. So we're delighted to be joined today from two patients, which is Frida, who is from the Dutch-speaking association in Belgium. And we also have Anastasia, who is from the Greek Patient Association, who will give us, I suppose, some of their experience and the burden of living with this complication of IBD. So Frida and Anastasia, I'll hand over to you.
Hello, my name is Frida. I'm 73 years old and I was diagnosed in 78. I was 27 years and they told me I had already Crohn from several years. But I had my first surgery only in 1998. And they saw I have fistula to the right sigmoid. It was better, but the activity increases again in 2003. So I note my years. And in 2004, so 6 years after my first surgery, I had ulcerated stenosis. And they gave me, I already took azathioprine, and they gave me also budesonide. Then in 2006, they tried to place a stent in my bowel. But yes, but it was not possible. In 2009, I had a balloon dilatation. And the years 12 and 13, I have 5 balloon dilatations for my ileum. But after that, I had a problem with my jejunum also. They discovered I had Crohn also in my jejunum. And then I had an obstruction again. In 2017, I had a surgery and they took away some centimeters from my bowel disease. But I had also perforation at that time in 2017. So I was very lucky. It was not in my whole bowel. And now last December, I had a surgery again because of a obstruction in my bowel disease. So no, it's not long ago. But the symptoms, my symptoms are vomiting, very nausea. My bowel is like a balloon, is very sensible. I can touch my bowel, and sometimes a little bit fever, but not too much. And diarrhea, of course, I had also. I remember once I was in Copenhagen to an eco congress, I think, And I was so sick in the airport, and I couldn't stand up. I lay down on a chair and I had to take my plane. I say to the steward, I was sick, but it was not contagious, and I was lucky. I had two chairs to lay down, because and it was next by the loo, so I was very lucky too. I was really very sick at that time, and I had already after 2000 I had breast cancer in 2011, so they had to stop all my medication. And after 3 years my Crohn came back. Yes, he was happy to come back to me. And I had so dilatations after that, 5. It's always drink for coloscopy. It was almost every 2 or 3 months I have to do that. That then after that they try to place the stent like they do for the heart, but it didn't click. It was not good. And then in 2017 I fell sick again, so sick. I was really sick. Then I couldn't eat. My husband wanted to drive me to the hospital, but I couldn't sit down. I have to lay down. So sick I felt. I was painful, my bowel, vomiting, always vomiting. It didn't stop. So I had surgery the day after that. And no, again, it began again last year in September. I was sick, nausea. I had to put my 2 fingers in my throat to vomit, because you feel a little bit better when you can do it. And so it was in September. It began again. Then after a month, I had already the symptoms again. The symptoms. Then after 3 weeks. Then after 2 weeks. So I felt it was an obstruction. So I went to the ER, and they saw that I have again a small sub-obstruction.
So I suppose for you now, Frida, at your young 73,
Thank you.
you've got to know, I suppose, the cycle of when you're going to be sick.
I know what it is. I feel what it is.
Yeah.
So first we thought that it was an intolerance to lactose, but it wasn't that. It was again sub-obstruction. So I hope they can find something, because I've been when I'm 78 or 80 maybe, they have to I need surgery again. It comes back.
It comes in that cycle for you.
Yeah, absolutely.
And Anastasia, I might ask you just a bit about your patient story as well.
Yeah. Well, hello. My name is Anastasia. My friends and people who know me call me Nastia. I'm 50 years old, and I have fibrotic Crohn's since 2009. I was diagnosed during routine, with a lot of air quotes, surgery of an appendectomy. It wasn't an appendectomy. I had already developed 3 fibrotic spots in my bowel. It wasn't easy, and since 2009 I had 2 more surgeries, so 3 so far, and I will probably have at least a couple more in the future. I have not been in full remission from Crohn's disease since 2015. I keep flaring again and again. And for me, the problem is that having fibrotic Crohn's means that any inflammation can potentially become a fibrosis. And since I'm almost always flaring, and I have already removed 3 stenotic spots, but I have 2 more that no one wants to mess with them for now. I always have to have some restrictions. they may not limit the way I live, but they also become uncomfortable. And most of all, these restrictions do not guarantee that I will not have more problems. So I may be in a low residue diet since 2009, but that does not mean that I don't have partial obstructions or full obstructions. And I know that there are guidelines saying that when you are in remission, you don't have dietary restrictions, but I haven't been in remission in the last 10 years. And that limits my diet and limits the things that I can do, going out with friends and everything. Actually, last week, like exactly last week, last Wednesday, I had suffered a partial obstruction. It started late night in last Tuesday, and I can now recognize the symptoms and know what's coming. And I can also evaluate if I have to go to the hospital or if I can suffer a bit at home and not have to deal with a hospital stay. This time it was an easy one, well, an easier one. So I did not need the hospital. I spent the whole day at home, ate nothing, drank some liquids, had a few bouts of vomit, one after another, and the next day I started getting better. For me, it was a mild one. The next one may not be the same. They used to happen at least 5-6 times a year. After the 2 surgeries I had in 2021, they happen in like once every 5 to 6 months. I still think they are a lot, and sometimes because I look healthy, sometimes I don't evaluate myself as having an episode coming, and sometimes maybe my friends, my family, my doctor may not evaluate the state I am in. I also had the balloon procedure because I have a fibrosis very close to the exit, and this affects my toilet schedule a lot. And also, there is no actual medicine. I'm in a protocol with a suitable medicine for Crohn's. I don't have other health problems. I'm in the highest dose, in the smallest time between doses. I'm having infusions. I'm still not in remission. And that means that I will make more inflammation that will cause more fibrosis. And since I have a very aggressive form of Crohn's, nothing can guarantee that I will not have more major problems in the future. Okay, still, I'm 50, so I try to live 100% of my life. I don't let Crohn's limit my interests. I travel, I have fun. I advise other patients to do so. I sure hope that in the near future, these advancements for treating Crohn's will also cover fibrotic Crohn's. That will bring some new therapy that will not follow us to the direction of having surgery. Because now, anytime we go to the doctor with symptoms, with a fibrosis, the solution is a surgery. I fought for more than 10 years to try to avoid surgery, and I finally had to have surgery because I had a partial obstruction every other day. Every time I ate something more than tea and bread, I had a partial obstruction, and I had to have a surgery. I was gonna die. So I think that these advancements will help us also. We used to be a smaller percentage. I know that now that we are, there are more of us. Still, We may be patients, we may have fibrotic Crohn's, but we are all strong. Yeah.
It's interesting, Anastasia, that you say that even you because you look well, because I suppose with IBD that is still a core foundation that we're invisible. The disease can sometimes be invisible.
And it also may, okay, I have a doctor who treats me regularly, but also if I have an emergency, I have to visit an ER room, and the doctor in the ER room will evaluate me not as a Crohn's patient, but as an ER patient, and he will see that I look okay. Most Crohn's patients look okay. No matter what type of Crohn they have. So they may not evaluate how bad I feel because my face is healthy and my body, more or less.
And I think from listening to both of your stories, we have the next speaker may be of interest. And I think there's a bit of pressure on him now after listening to how both of you at various stages of your life have what you've had to go through and what you've had to deal with it. So I might invite, if that's okay, and we'll come back, Frida and Anastasia, later for the roundtable, but I might invite Tim van Kamen to join me on stage. So we've discussed the lack of effective treatments options, making life even more challenging for patients. However, Tim, you're going to bring us some promising news, which is on the horizon, which is the SNOVA study. So if I'm correct, this study is testing a potential first-line treatment for patients like Frida and Anastasia. So you're going to talk us through some of the insights about this exciting development. And I'm sure after listening, you don't feel any pressure.
Well, allow me to first thank EFCA for the invitation. It's absolute honor, and also Frida and Anastasia, listening to your story. I think that's why we do this. That's why we try to develop new medicines, and we hope to indeed at some point provide a solution. I don't think we have all the answers yet, as very nicely said. I think there is still a lot of research and collaboration ongoing, and we hope to contribute to that. I think it's a joint effort, a Horizon project like FIBROTARGET and others. I think that's what we need. And we really like this partnership. So more than happy to give some insights into what we do. We are a small biotech company in Belgium with today 80 people, and we really focus on fibrotic diseases. And one of them obviously being intestinal fibrosis or scarring tissue in Crohn's disease, but also others in lung disease, for instance, fibrosis in the lung. And today I would like to share some of the insights of what we do, what we are working on, and what study we are running today to hopefully provide some of the answers that Frida and Anastasia are looking for. And maybe we can have a quick look at the slides. I won't take too much of your time, but
no, the floor is you for patients. The floor is yours. So
absolutely. So thank you very much. You can go to the next slide, please. So as I very nicely said in the introduction, there is today a search for targets or pathways that actually treat or cause fibrosis. One of them is already an older pathway that has been known for quite some time, and that's the TGF-beta pathway. It's a growth factor pathway that actually is driving the formation of your scarring tissue. This is not a new concept. This has been tested before. There are drugs that have been developed to inhibit this target, and they have even shown promising effects in other indications. But the downside of these therapies was that when you block this in your entire body, so not only in your gut, but also in other organs, that this could cause some side effects that are not manageable, let's say, in patients, and therefore have only been considered at some point in patients with an oncology setting or with treatments for a short period of time, 2 weeks on, 2 weeks off. And that's why we started from this concept and tried to develop a drug that is actually only active in your bowel, in your gut, and not in your system to avoid these potential safety risks. And if you go to the next slide, the concept of that is pretty simple. It's a pill, it's a capsule today that you take orally. This compound is then absorbed throughout your GI tract, so from top to bottom. There's part of it that we find back in your stool, so we know that it really travels throughout your gut, and it's absorbed in your gut wall where actually the scarring tissue is and where it has to be active. There it can try to block the formation of new scarring tissue. Once it then enters into your bloodstream, this is the normal flow for anything you absorb. It goes through your liver, and in your liver, it's rapidly metabolized. And what that means is that the compound becomes inactivated. So meaning it cannot have its biological function anymore in any other organ in your body. So it is active in your bowel, and it's not active through the rest of your system. And this is a way for us to mitigate some of these side effects that have been seen with other drugs in the past. Now, this is obviously theoretical, and this is what we have been evaluating as part of drug development. First of all, in animals to test the safety of the drug. Also, we've tested it in healthy volunteers. And we have now started, and that's on the next slide, a first study, unique in its kind, in a way that it's the first study that really is going to evaluate the safety of this compound in patients that have fibrostenotic Crohn's disease or fibrosis in their gut. The study is unique in a sense that, as Séverine says, it's also the first time that an antifibrotic is going to be tested, but also we need to find ways to evaluate how you are doing. And that's based on questionnaires, and there is a new questionnaire that is actually developed to score how you feel, how your symptoms are, the vomiting, the bloating, the cramping, the diarrhea, as Frida described. And this questionnaire is called the ESPRO, and it's the first time that we're going to assess how that questionnaire performs. And also on the imaging side, so you classically in other clinical trials or in the past, you undergo from time to time colonoscopies. We're going to do that here as well to collect some biopsies for research purposes, but also we're going to take another form of image, which is called an MRI. And on that image, we can really assess how your fibrosis is doing. So how the study is constructed is that in a clinical trial, there is always a placebo arm. That's our control arm. You will get, obviously, during the study, your standard of care therapy. And we're going to evaluate 2 doses of our compound, which is called 1-9, a high dose and a low dose. We're going to test this for the first time in 90 patients. It's a global trial, so we conduct it across several countries, as you can see on the right. And it's on top of your standard of care. And I think that's important to keep that in mind. As Séverine mentioned, there are multiple therapies available today, very promising ones on the anti-inflammatory side, so to block the flares. But we can give this on top because it brings another layer of treatment, the antifibrotic therapy. We're very pleased that the study has started, and we hope to be able at some point to share the results. But it's, again, thanks for the opportunity to EFCA and others to present our landmark trial, and we hope to provide at some point good news on the performance of this asset.
Thank you very much, Tim, and definitely no pressure. What I might do, and again, I would like to remind everybody, if you're watching live, you can pop your questions or comments in the comment box. But I might invite all the speakers back on screen or back around the table, and we will have some questions. And it takes a second or two for us all to appear, but we're all here now. I suppose potentially, while questions are coming in, I have a question, I suppose, for the professors. Are there any, I suppose, alarming symptoms we should pay attention to as patients? I suppose maybe for patients that aren't as experienced as Frida and Anastasia, but as, I suppose, lower down the line of experience.
If I can, Frida and Anastasia told us exactly what they experienced during their disease course, and summarizing the classical obstructive symptoms that recurred many times in their life. So listening to them was to me like remembering a textbook of gastroenterology in the chapter of Crohn's disease, because they were very accurate in describing bloating at the beginning, abdominal pain, cramps, nausea, and maybe that is not only one day, but is also the day after and the day after, and then every day or every other day, and at the end, terrible abdominal pain and vomiting and improvement of symptoms. So this is the classical symptoms of stricturing, but there could be many other aspects to discuss, in my opinion. But they were very accurate indeed.
And Perhaps if I just may add, I found it, and thank you also, I think, Frida and Anastasia, for describing it so vividly. I think you could really imagine what you have gone through again and again, and how you listen to your own body. And I found it very impressive how you said you have created an own feeling, how you feel. You can really put it on a certain level. Is this like you always felt the last times, or is this something more severe? So you have your own alarm symptoms because you're so accustomed to it. You can really gradually, better than any scores that we have, really give us an information how you feel. And that's what I found very impressive, that you develop an own sense for your symptoms, and this is something that's not normal. This is something where I probably even have to go to the emergency unit because this is more severe.
And I suppose Frida and Anastasia are the professors, or Tim, is there one symptom, if I was watching this as a newly diagnosed patient and I really don't understand, and I think maybe it's a flare, or this is my new Crohn's, or that you would kind of pinpoint and say, yes, that's it. That's the one that is the one that I watch out for as a patient. Oh, Frida, I think you're on mute there. Oh, we'll unmute you.
Okay. When the symptoms come back, you have to know that it is not normal, your Crohn's disease. But you have a lot of nausea, you have to vomit it. You can have it once, but when you have it 2, 3, 4 times, it's not normal again. So that's how I feel. There is also otherwise. That's
the reoccurrence of it is
yeah.
And Anastasia, would you agree with that? It's that
for me is I have 2 places in but for me is a bit more specific. There are 2 places in my bowel which are former anastomosis from the surgeries. And I don't know why, but I can touch them from the outside, from the skin. When they get hard, an obstruction begins.
And I suppose my point of asking that question is that everything with IBD is very personalized. So I suppose even just hearing your 2 sides, you're both, I suppose, identify it differently. The professors, sorry again to put you under the spotlight. Does fibrosis always lead to a bowel resection? Are there alternatives, do you think, to manage it?
Absolutely. So there are patients who are walking around with fibrosis and stenosis for many, many, many years. I think also the story of Frida, these stenosis do not come overnight. And what first symptoms sometimes is also that patients start to change their diet, and they start eating white bread. They start taking out the raw vegetables and fruit, and so then they have less pain. And so you can sometimes live for a longer, sometimes years, with the stricture as well. Of course, if it gradually gets worse, then at some point, very often you get, as Frida and Anastasia said, you get one final drop that gives you then potentially a complication or a perforation as well. Are there other ways to treat it than surgery? Let me first stay with the surgery. You can take the segment out. But of course, if it's very long, you risk of losing a lot of bowel. This is why the surgeons have developed techniques to open up the stricture, but to leave the bowel inside. We call that a stricturoplasty. And that is a way, technically, you cut in the length of the stricture, and then it's like you put your hands in and you open it up in the other direction, 90 degrees, and you close it in the other direction. So this is a way of opening the stricture. Usually, typically, you do that for short strictures, not for very, very long strictures. It becomes more difficult. Another way was mentioned already. by Frida, balloon dilations are other ways of opening up strictures, but only for short strictures. You can only do that when your stricture is maximum 5 centimeter, because we do not have balloons that are that long to open up strictures. So very often still it leads to surgery, yes, and very often surgery with a resection of the bowel.
And you mentioned there then that in your presentation that the likelihood of resurgery or second surgery then is common.
Yeah, it's not. It's quite common actually. The
Quite common.
The statistic say that 40 to 50% of people that have received within the first year of disease one bowel resection may have a second one in the next 10 years. I mean, clearly is a statistic, but just to give you an idea that if you receive a bowel resection, you can receive a second, even a third along the disease course.
Yeah. I had already four surgeries.
Yeah, you are a textbook, Frida, as I told you.
We have a question in online. Do you prefer to do endoscopic dilation under general anesthetic or conscious sedation? And taking it into consideration that sometimes it's not easy to get an anesthetic doctor.
Well, in my hospital is with propofol and the anesthesiologist.
Okay.
So I think we also do it in Germany with sedation. I think we are not using anesthesiologists, so we can do a course and learn it how to do it. Mm-hmm. So there are always numerous people in the room, and one is just looking for sedation. So I think the safety is quite well preserved.
Yeah.
And in our country, we use conscious sedation and also propofol sedation. So there are different. It depends, I think, from patient to patient as well. And I do realize what is asked in the chat. It's not always easy to get anesthesia and so on. So I think there are several ways of doing it, as long as the patient is, of course, comfortable. Yes.
Cool. Frida and Anastasia, before I seek a medical answer on this, I'm just going to seek a patient answer first. In your experience, is there anything preventative that I suppose aids you to getting sicker? Is there any preventative measures that you can think of from a patient perspective?
I don't know if I can say anything about it.
Anastasia, is there anything that you've kind of noticed?
Only the low residue diet. I avoid everything that has undigested fiber. Or eat them in very, very small quantities and chew them very, 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 very well. But other than that, no. And sometimes even this is not enough.
Yeah.
Sometimes I don't eat.
In some situation, could be useful just spending some period on total enteral nutrition, just drinking formulas that in stenotic Crohn's disease could be useful just to relieve. And they have also some anti-inflammatory effects, unfortunately not anti-fibrotic as we were discussing at the beginning, but they could be useful.
Okay. Back to the FIBROTARGET project. How do you envisage its impact and contribution to the future for patients?
Perhaps if I may start, I think it's a very nice combination of, let's say, basic science, but at the end, why are we all doing this? We are collecting data at the end of the day to help the patients. And I think Frida and Anastasia very nicely described the burden that they have with this disease. So I think this is, and that's the beauty of it, because it's combining basic scientists and clinicians. And this is always something where you learn from each other, because we as a clinicians can say, okay, this is a problem in the clinics, and the basic scientists can say, okay, then we'll go in that direction. And we can learn from them and they from us, and together, of course, as we are all also involved in science. So I think on a basic science part, we would try to see what is the best target for a new therapy, to see perhaps at least in the laboratory what has a good anti-fibrotic effect. But we all know sometimes library is important for the first proof of concept, but then you have to go into clinics to see, does this really work in an affected patient? I think that is it, because in the lab, we'd like to find what is the best target. And we have different compounds that have already been developed against this target. And once we have a clear picture, what might be the best target, we can then go into a clinical trial. And I think Tim very nicely described it. You have to really think also, okay, clinical trial, what do we measure? How can we see, how does a therapy work? When does it work? A patient has to feel better, of course. I think that is indispensable. But also on the imaging part, can we see that the stricture goes back, that perhaps the stricture is opening up again? I think that would be a beauty. And then also, of course, the clinical symptoms would be better. So I think that's a nice combination of going from the bench, as we say, from the laboratory to the clinics to the patient. And I think that would be a full circle. And I think that is what's driving also this whole consortium.
And if I may add, we are absolutely wanting and asking for your help in two ways. We think of starting the trial next year, and then of course we hope that there will be patients that want to go into the study and that test the medication. But beforehand, we are finalizing the study protocol, and this is where EFCA comes in. We are asking, we as physicians think that this and this and this should be done in the trial, and these examinations we want. But then we want to hear from patients, is this acceptable? Is this too much? Are you willing to do this as well? So I think it's very much in collaboration. And this is why we are very grateful that EFCA and that the patients are also wanting to help us. Because if we in the end design a trial and then in the end no patient wants to go into the trial because it's too difficult, too much of a burden,
it's finding that balance, but I think, and patients will come at it from a different perspective than the medical. So it's about that whole round table. Tim, I suppose your study, if there's people listening or are watching, what is the eligibility criteria? And I suppose how can people join, or can people join, or?
No, very good question, and I fully agree with what the colleague said. I think it's indeed always trying to find the balance. So probably not all patients are by default eligible for a clinical trial. It's a scientific experiment in a way, so you have to try to define your patient population as good as possible. Also, in this particular case, it's a completely new era, as you started in the with the introduction. So there is no precedent. So we actually rely on physicians to guide us on how to define the patient population. And for this first trial, as we are looking at safety of the drug, we try to find patients that have a stenotic disease, but are actually well controlled in a sense that they don't have an acute situation. They don't have a sub-obstruction or an obstruction. Their symptoms are manageable. They can cope with maybe indeed, like Anastasia described, some dietary modifications. So that's the type of patients that are today eligible for Stenova. And obviously we try to have an objective qualification of these patients, meaning that we will take images to indeed confirm that there is a stricture present, in order to be also able to assess whether there is a potential improvement over time. So these are the study is indeed open. As I said, it's open in a number of countries, not in all countries. And for that, you can also look indeed on the public websites like the clinicaltrial.gov, and even on the EFCA website, you can see where the study is actually active. So patients can actually find the information there on
and where to go.
Whether they can reach out to any of the participating physicians. Yeah.
Okay. I do like sometimes when there's not many questions, because that means that everything is quite clear, which is good sometimes. And I suppose around the table, not much pressure on you, Tim, or the FIBROTARGET project for patients, because there's a huge amount of pressure on you all to help us. Could I ask you, I suppose, for some closing words in relation to... Oh, sorry, 1 second. I say there's no questions. Do you have any other targets in the pipeline besides ALK5 that have a potential for translation to the clinic?
Yeah, I think we have. There have been some targets already identified, because there are already some data that imply, yes, they could be suitable targets. So, for instance, TYK2 is one of the factors that might where we know that it also has, if you inhibit it, it has an anti-inflammatory property. But we are investigating if this might also be something that we could follow up, indeed. And there's also the so-called inflammasome. So you're seeing we're going into the molecular depths to see which are the targets that might suit us, and it's called NLRP3. And so there are also various other targets that we are at the moment indeed investigating, large groups across all Europe. So I think that's also very nice because we can combine and everyone has their expertise in certain methods. So we are really looking now in the laboratory which might have really the best potential to have then an antifibrotic effect in the clinic, in the study, because that is at the end of the day what the compound has to fulfill.
And just we have a few minutes to close. Severine, if people wanted to find out more about the FIBROTARGET project, how can they do that?
I would first direct them to your website, to the FCAL website, and then through your website. We, of course, have our own website as well. So type in FIBROTARGET, you will find it. But I think if they go through FCAL, they will also...
Through us first.
Absolutely, absolutely.
Yeah. So I suppose anybody watching this, we normally send out updates in relation to all our European projects that we're partnering with. So any of our members will get updates. If I go around the table, the virtual one, and just ask for maybe some closing comments. And Professor Vermeer, if I come to you first. You opened this afternoon, so if you could have you anything to say on both the future of FIBROTARGET and also, I suppose, the challenges ahead for yourselves?
Yeah, I truly, truly hope, but I also believe that in the next 5 years, we will make very significant breakthroughs in finding something against fibrosis. When I look back now at I've been in the business for 30 years. When I look back at the progress we made in the last 20 years, it's huge on inflammation. Let's now just repeat that with the same collaboration throughout the world, Europe and beyond, also for tackling fibrosis. So I'm very hopeful for the future. So Frida and Anastasia, hang on there. There will be better times and drugs also for your specific disease.
Okay. And Professor Ermisi, have you any closing words?
Yeah, I mean, fibrosis is one of the largest unmet need in inflammatory bowel disease, not only in IBD, but we are speaking on IBD. And we do not understand all the mechanism, and we are not able to predict, and we are not able to treat actually. So when I was asked to join the project from Severine, I was really excited, having read all the working parties that are divided and consecutive in this project, from really to the bench, from the bedside, hopefully next year. And so I think that I am very positive to hope that we will find something that really could change lives of people like Frida and Anastasia.
And Professor Tara?
Yes, I think we have clearly learned now also in this past hour that we really have a task to fulfill. And I think what I really like, this is a collaboration across Europe with, I would say, excellent scientists and good friends. I think this always helps if you know each other and if you can interact with each other, and we all have the same aim. And there's a clear structure. Where do we start and where do we want to end? And we always also evaluate ourselves. Have we reached the aim that we want to reach? So I think that's a very good framework, of course, to go that way. So I'm also very hopeful, because if we look back, there has been progress. There's been a lot of attention on this field now. And the more people work on this field, the better is the chance that at the end of the day, we'll have something to help all affected patients.
And Tim, from yourself and Stenova's point of view, the Stenova study.
Yeah, it's hard to add to what the colleagues said, but I fully agree. I think it's a partnership. I think we're all aiming for the same. So I would say to Frida and Anastasia, stay strong, be peaceful, that there are a lot of people working hard to try to find a solution. So thanks for the testimony. It's really enlightening, and that's what keeps us going every day. So stay strong.
And Frida and Anastasia, I know you mentioned earlier, Anastasia, I think it was you, that it was a small club, but it's growing. So on behalf of your other patients and your other club members, Frida, could I ask you for some closing words from your perspective?
Yes, I want to thank you in the name of all our IBD patients for all your hard work. And we hope it will be very soon. No surgery anymore.
And Anastasia, anything from yourself? Oh, Anastasia? Oh, yeah.
Stay strong and kick Crohn's butt.
So thank you very much for everybody who joined us this afternoon around the table. We thank you, and on behalf of EFCA, we're delighted to partner with yourselves, and equally for
Thank you too.
all patients. We're very, very happy to continue, and I'm sure as patients we will put pressure on every now and then to make sure that it continues and the goals are reached. But thank you so much on behalf of all the patients. For everybody watching, thank you for joining us for another EFCA talk, and hopefully we will see you soon again. Thank you very much.
Bye.
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 Thanks.
Thank you.